Hello, everyone, and welcome to today's webinar, The Role of Interferon Gamma Release Assay in the TB Testing Program. I am Michelle Ashton of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by DiaSorin. To learn more, please visit diasorin.com. Let's get started. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I'd like to now present today's speaker, Marie-Claire Rowlinson, CLIA Laboratory Director and Assistant Director at the Bureau of Public Health Laboratories in Jacksonville, Florida. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Marie-Claire, you may now begin your presentation. Welcome.
Hello. Well, thank you very much for inviting me to speak today, and I'm going to talk about the role of the interferon gamma release assay in the TB testing program. The learning objectives today are to review the role of IGRAs in the diagnosis of TB infection, summarize some recent changes in IGRA testing, focusing on guidelines associated with IGRA testing for certain populations, and then lastly, I'm going to discuss the implementation of IGRA testing in a public health program. If we look at tuberculosis in the US, the most recent report from CDC, which came out in March of 2020, there were 8,920 new TB cases in 2019 in the US, and that's a TB incidence of 2.7 cases per 100,000 persons. And a review of the data showed that the rate of TB among non-US born persons was 15.5 times higher than in US born persons. 4 states contributed approximately half of all US cases, including the state in which I am, Florida, which reported 558 cases. And although the number of cases did continue to decrease, it was a 1.1% decrease from 2018, the current trend is not sufficient to reach the goal of TB elimination in the US. So what is this goal of TB elimination? Well, TB elimination would be fewer than 1 case per 1 million persons. And as I said, at the current rate, modeling does not predict the US would reach this TB elimination goal in the 21st century, or at least not without considerable concerted efforts that would include overall investing in programs that identify, test, and treat populations at high risk for TB, but also focusing on populations at risk for latent TB infection, LTBI, and investing in enhanced detection and treatment of latent TB infection. So today I'm going to focus on latent TB infection and the importance of detection of LTBI. Approximately 3 to 5% of the US population has LTBI, and without treatment, 5 to 10% of healthy persons will progress to TB disease in their lifetime. And this percentage increases substantially among immune-compromised patients with LTBI, including persons receiving immunosuppressive therapy or those who are immunosuppressed as a result of a certain underlying comorbidity or disease, for example, uncontrolled HIV. And in the CDC report from 2018, it highlighted nearly half of TB cases in non-US born persons were diagnosed greater than 10 years after arrival in the US, indicating that a lot of this TB was reactivation of remotely acquired LTBI. And in fact, even though half of these are detected at greater, or they progress to TB disease at greater than 10 years after arrival, of course, many more of those cases are also remotely required. And in fact, it's estimated to be responsible for more than 80% of domestic active TB cases. As I said, TB elimination will require enhanced surveillance, detection, and treatment. And of course, I highlight their detection because here the focus is laboratory diagnosis, and we can really see the key role that the lab is going to play in TB elimination. And this is for LTBI among at-risk populations. So the populations recommended for focused efforts according to CDC and the US Preventive Services Task Force include persons who currently live or previously lived in congregate settings, persons born in or who frequently travel to countries where TB is prevalent, healthcare workers and others who work in places where there's a high risk of TB transmission, immunocompromised persons who have a higher risk for developing TB disease once infected, and persons who are contacts of a person with infectious TB disease. And TB, as we know, is a preventable disease, and prevention really starts with the detection and the diagnosis of LTBI. So let's have a look at some of the diagnostic testing for LTBI. Well, the tuberculin skin test has been around for over 100 years, and this is the detection of cellular immune response. It's the administration of an intradermal injection that produces an immunological reaction to Mycobacterium tuberculosis. And this can be measured by the skin's response, and it's read at 48 to 72 hours after the injection. One of the main limitations of the tuberculin skin test is that it's not performed in a clinical or laboratory setting, and it relies on the interpretation of the reader. It must be interpreted in conjunction with the person's risk. And the tuberculin skin test can elucidate a non-specific reaction, for example, in somebody who has been vaccinated with the BCG vaccine. Or there may be no reaction in certain persons, for example, HIV positive. So the no reaction anergy could produce a false negative because there's an inability for the skin to react. This may also happen if the TB infection is very old, or it may happen in persons who are very young. There's also the possibility for false positives with this if someone has an infection with a non-tuberculous mycobacteria, like I said, previous BCG vaccination. And of course, if the test is not operated correctly, there could also be issues with false positives or false negatives. So the other method for diagnostic testing for LTBI, which is still looking at a detection of the cellular immune response, is a laboratory-based method that detects sensitization to MTB by measuring release of interferon gamma and in response to synthetic peptides that represent specific MTB proteins. And these are interferon gamma release assays, and require a blood draw from a person. And like I said, looks at release of interferon gamma, either directly interferon gamma or interferon gamma producing cells that are then either measured by ELISA or ELISpot. There are also some limitations with IGRA. There are fewer issues with non-specific reactions, but an IGRA cannot distinguish an old from a new infection, and it cannot be used to monitor treatment. As with the tuberculin skin test, the TST, there is possibility for no reaction or allergy and a false negative. This may be if a person is severely immune compromised. And there are also some other challenges with IGRA testing. For example, like I said, it requires a blood draw, and blood samples must be processed within a certain time frame after collection. There can be errors in the collection and transport of these blood samples. And there's limited data on use of IGRAs for children younger than the age of 5, persons who are very recently exposed to TB, severely immune-compromised persons, and also the role of IGRA if they are used serially. One of the other disadvantages of IGRA is it's more expensive, for example, than the TST. So cost is also a factor. Nevertheless, there are many advantages of IGRA versus TST, and I've just put up a comparison of these two methods, which is part of the CDC core curriculum guidance. So the advantages of performing IGRA, as I highlighted, it's a laboratory-based test. And so with that, there's the use of positive and negative controls, objective results, defined interpretive criteria, and there's just a robust quality assurance around the entire process. And there's the opportunity to automate in the lab setting. It's a single patient visit, so unlike the TST where the injection is administered and then read within 48 to 72 hours, this is a single blood draw for the patient. Results are also available quickly within 24 hours or sometimes less. IGRAs are unaffected by BCG vaccination, and there is no cross-reaction with the majority of non-tuberculous mycobacteria. So next, I'm going to talk about some guidance related to the use of IGRA, some which is quite recent. But if we look at the CDC guidelines published in 2010, they did state that IGRA could be used instead of TST to aid in the diagnosis of TB infection, and that it was preferred in persons who were BCG vaccinated and persons unlikely to return to have their TST read. These guidelines have recently been updated. A 2016 joint statement from CDC, the American Thoracic Society, and Infectious Disease Society of America instead strongly recommended IGRAs for all BCG vaccinated persons and those unlikely to return for the TST reading, and additionally for those above the age of 5 with low to intermediate risk of progression, regardless of BCG status or likelihood of returning. If it does say in this statement for persons under the age of 5, IGRAs was acceptable, but TST still preferred. And as I alluded to earlier, this is about there being more limited data on this age group for IGRA testing and its performance. This joint statement also said that IGRA or TST, there was no preference in individuals greater than 5 years of age with high risk of progression could be used. Another recent change was in the guidance to civil surgeons, and this is for immigration testing. So since October 1st, 2018, civil surgeons must use an IGRA for this immigration testing in alignment with CDC recommendations. So the TST is no longer an acceptable test to be performed in this setting. And in May 2019, CDC also updated guidelines regarding TB screening and testing of healthcare personnel by IGRA or TST. The guidelines still state that TB, IGRA or TST should be performed upon hire to get a baseline for the new employee. But IGRA should also, or TST should also be performed if there is a known exposure or ongoing transmission at a healthcare facility, and that IGRA or TST can be performed annually for certain groups who are at increased occupational risk for TB exposure. I think one of the things to highlight here is that there's quite an emphasis on the local jurisdiction and the healthcare facility to make the judgment upon when testing should be performed for certain groups at higher risk. In the document, it mentions pulmonologists and respiratory therapists. Laboratory personnel are not specifically mentioned, but I think laboratory personnel performing testing on TB would fall into this category. In the absence of a risk, routine serial testing should not be performed. So let's have a little bit of a look at the IGRAs that are available on the market. There are two FDA-approved methods on the market in the US, the QuantiFERON TB Gold Plus from QIAGEN. And this was first FDA-approved IGRA on the market back in 2001, but has evolved since that time. And the T-Spot TB from Oxford Immunotech, now Quest Diagnostics. And if we compare these two interferon gamma release assays, you can see that there's slightly different processes with the collection and the detection. So the collection process needs to be adhered to in terms of timing. There are slightly different antigens that they detect. The QFT Gold Plus now includes additional MHC1 classes, and the two assays are measured slightly differently. The QuantiFERON looks at interferon gamma concentration, whereas the T-Spot looks at the number of interferon gamma producing cells. And there are slightly different ways of interpreting the results. There have been some recent changes of note with IGRA testing, and I wanted to address some of those today, specifically with the QuantiFERON TB Gold Plus. This became available in the US in 2018, and the prior assay, the QuantiFERON Gold in Tube, was no longer available in the US after June 30, 2018. The TB Gold Plus assay has 4 tubes instead of the 3-tube setup for the Gold in Tube assay. And with the new TB Gold Plus assay, there's an addition of a TB2 tube. So with the 4 tubes, there's nil, mitogen, TB1, and TB2. And the TB2 tube also looks at CD8 T cell responses. So this assay is optimized for CD4 and CD8 T cell response and has a sensitivity greater than 94% and a specificity greater than 97%. CD8 T cells are an important component of the host immunity to MTB, with studies showing significantly higher CD8 T cell responses in patients with smear-positive or active pulmonary TB disease than in smear-negative or LTBI patients. And CD8 T-cell responses are also identified in those who are recently exposed contacts of patients with active TB infection. The other advantage of adding detection of CD8 T-cell response is that patients co-infected with TB and HIV have been shown to maintain CD8 T-cell responses, even though they may have low CD4 T-cell counts. So the addition of the TB2 tube and inclusion of these MHC class I peptides for the stimulation of CD8 T-cell improves upon the sensitivity of the assay to detect TB infection, both latent and active, and including infection as a result of recent exposure and in patients with immune-compromising conditions and potentially depleted CD4 T-cell counts. Another big change with the QuantiFERON TB Gold Plus assay is the option for a single tube draw. This is drawn into a lithium heparin tube, and it has also allowed for the processing time to be from collection to processing the lab extended to 2 days. So with the single tube draw, 1 ml of blood 4 ml of blood minimum is collected into the single tube, and then 1 ml in the lab is transferred into each of the 4 QuantiFERON Plus tubes. And as with the prior QuantiFERON assay, there are specific parameters around timing related to when the sample is collected to when it must be processed in the lab. But with the single tube draw, it can now be refrigerated for up to 53 hours prior to transfer to the 4 QuantiFERON Plus blood collection tubes, which is a good addition if samples are being collected and potentially shipped overnight for testing. And lastly, there are new automated solutions which have greatly improved the efficiency with which IGRA can be performed. Here, pictured here in our lab, is the Liaison QuantiFERON TB Gold Plus assay, and this is the instrument that from DSRN, the Liaison XL, and it's fully automated. It's a chemiluminescent analysis. It was recently FDA approved, and it's 46 minutes to the first result. So it has enabled full automation, efficiency, accuracy, and enhanced throughput. One of the other things of note here is the flexibility for other additional assays that can be automated on this instrument. For example, in our lab, we most recently have brought on the SARS-CoV-2 IgG assay. And the other advantage here as well is that the instrument can be interfaced. So for efficiency purposes, the reporting of results straight into our LIMS is a great benefit. So when we look at IGRA in the TB testing algorithm, we can see that IGRA can play an important role in detecting LTBI as well as active TB disease. So IGRA testing is really part of a robust algorithm for the lab diagnosis of TB. That also still includes AFB smear, culture, molecular diagnosis, and antimicrobial susceptibility testing related to the diagnosis of active TB disease. I've highlighted here a recent publication of the microbacteriology practice guidelines from the Clinical Microbiology Reviews, which is a comprehensive guide to clinical microbacteriology testing and does include a section on IGRA as well. So if we summarize what we've talked about so far, LTBI in the US, I think it's important to highlight that targeting LTBI is going to be necessary for the elimination of TB in the US, and that the lab and detection of LTBI is going to play a significant role. Non-US born rates are not decreasing at the rate of US born, and an estimated 80% of active TB cases are a result of remotely acquired TB, and therefore we need to be detecting that LTBI before these persons get active TB disease. There are shorter, safer, and more convenient LTBI treatment regimens available, which hopefully will encourage people to take treatment for LTBI. And the detection of LTBI can be improved by the preferential use of IGRA over TST in certain persons. Lastly, a most recent update, June 2020, CDC has provided a summary of US recommendations related to latent TB infection. And it emphasizes that eliminating TB requires expanded testing and treatment of latent TB, and that testing for TB infection should be a routine and integral part of healthcare for patients with an increased risk. Lastly, let's switch gears a little bit and talk about the role of IGRA testing within a public health TB program, and focusing on Florida Department of Health. So Florida has a system of TB care that ensures the implementation of key strategies of an effective statewide TB program. Treat to cure patients with active TB, protect close contacts to patients with active TB, prevent future TB disease by identifying and treating LTBI, ensure infection prevention practices are in place in facilities where transmission is likely if an individual with undiagnosed TB disease is present, for example, the homeless population and correctional facilities, and to monitor and evaluate performance to ensure that data-driven interventions improve program outcomes. Florida Department of Health utilizes both IGRA and TST for the detection of LTBI. Either test may be used, but certain situations may favor one technique over the other. For the Florida Department of Health, IGRA utilization has been as part of the establishment of a clinical diagnosis of TB disease, in contact investigations or outbreaks of public health importance, and monitoring of certain key populations to rule out TB infection. For example, the shelter card program, which I'm going to talk a little bit about. To highlight the role of IGRA within a public health program, I'm going to talk about two examples today. One is with our Duval County Health Department and the Shelter Card Program, as I just mentioned. And then another initiative with Pinellas County Health Department, where there was an investigation of public health importance. So the Duval County Health Department TB program is part of the Florida system of TB care, which ensures that clients with active TB disease or latent TB infection receive consistently high-quality care from diagnosis to completion of treatment through case management and patient education and coordination of local and state resources. So you can see here in this flow diagram, when there is a suspect TB case, the important role of getting a diagnosis for the patient, and care for the patient, and hopefully cure and also prevention of transmission. And patients with positive skin test or IGRA and an abnormal chest X-ray or symptoms of disease or risk factors for development of TB disease are referred to the Department of Health, Duval County Health Department, Center for Specialized Pulmonary Services. And they really focus on monitoring specific patients for latent TB infection, and they include the shelter card program, which is related to the homeless shelters, the refugee program, and jails and prisons. They offer IGRA testing as part of the shelter card program for any homeless person seeking shelter in any of the 4 large shelters in Jacksonville. And the shelter card program was established in response to an outbreak in the homeless population in Duval County between 2004 and 2012. And it has been an effective surveillance initiative that identifies TB disease in persons visiting local homeless shelters, helps eliminate transmission and reduces risk of progression to active disease with earlier detection of LTBI, and enables timely treatment for those identified with LTBI. So this was some data from 2019, the number of clients that had been seen at the shelter card as part of the shelter card program, the number of shelter card visits, number of IGRAs performed, and then new LTBIs detected. And there was no persons who were suspected of having active disease or progressing to active disease. But you can certainly see that this program was effective in identifying LTBI among this population. And these are just the 4 shelters that you see on the bar graph here, and the percentage of clients testing positive by shelter. The highest, just over a little over 5%. But as I said, this has been an important program in identifying LTBI, and certainly identifying LTBI earlier on to prevent progression to disease for that person and transmission to others. To support implementation of this program, the Bureau of Public Health Laboratories in Florida implemented IGRA testing specifically for the shelter card program, and this was initially supported by a grant, but enabled the Public Health Lab to support this important program. Initially, QuantiFERON Gold in Tube was implemented, and subsequently in 2018, the QuantiFERON Plus. We started out with the Dynex DS2, which is an automated EIA instrument, which will hold 2 plates. We switched to a Dynex Agility, which has a higher capacity. And I think the important thing to highlight here was that as part of this, we made sure we standardized the reporting language and also reported the testing results values as they were useful for the healthcare providers. And overall implementation of IGRA in the Public Health Lab reduced the indeterminate rate because prior to this, all IGRAs collected for the shelter card program were being sent to a commercial laboratory for testing. It also improved turnaround time and general overall quality improvement. And subsequently, we are also about to switch to the DSR and Liaison XL as our instrument for testing. And here's how the QuantiFERON Gold Plus results values look like, and the interpretation are either positive, negative, or indeterminate. And I've provided an example of a report from our lab, and this is a positive result that you can see there, and just highlighting again the importance of standardizing reporting language so that clinicians can make decisions based on these results. Department of Health investigation in Pinellas County was another project where the Public Health Laboratory played a role. We wanted to be able to support a contact investigation, and since often with these investigations, collection is in the field and collecting 4 tubes can be challenging, prior to implementing the Gold Plus, there had been a preference to perform T-spot instead, since that required only a single collection. So with the single collection device with the lithium heparin tube, the Bureau of Public Health Labs was able to work with Pinellas County on this investigation. So there were actually 3 investigations. In one, there were 6 positives. In the second, there were none, and in a third, there were 2 positives. So it was certainly helpful to use a single tube draw for contact investigation purposes, and clearly can identify additional persons who may have been exposed. And for the lab, we had to obviously implement the single tube draw. So there were some changes that happened in the lab to enable us to be able to process the single tube draw, because the lab is then responsible for aliquoting from that single tube into the 4 quantiferon tubes. We actually purchased an automated pipetter to prevent errors and for ease of use, ergonomically, when pipetting from a single tube into 4 multiple times. We also did a small validation of the single tube draw and compared to the 4 tube draw with 10 patients and had 100% agreement. There were several advantages with this outbreak investigation for the single tube draw, and in general for any contact investigations of public health importance. As I said, the ease with which healthcare providers can collect samples in the field, there's easier shipment with minimal pre-analytical steps, and the Public Health Laboratory performs the aliquoting and has greater control over quality from pre-analytical perspective, so fewer indeterminate results. A lot of indeterminate results with the quantiferon assay are usually due to errors in the pre-analytical process. This also enables maintaining of data within the Department of Health for surveillance purposes. In summary, utilization of IGRA is recommended for certain populations and has advantages over the TST skin test. And utilization of IGRA in a public health setting has also improved testing for certain patient populations, more rapid identification of latent TB infection, and linking to care and treatment as appropriate. With the QuantiFERON Plus assay, the single tube draw has brought advantages to public health for investigations of public health importance and in certain patient populations, for example, homeless and prisons and jails. And I should also mention here the addition of the TB2 tube and the detection of the CD8 T-cell response has also brought advantages with improved sensitivity and ability to use this assay with immune-compromised persons, for example, HIV-positive persons with potentially lower CD4 T-cell responses. And lastly, implementation of IGRA in a public health setting improves reporting for public health surveillance, since IGRA and LTBI is not reportable in most states. And I should also finally mention the importance to continue to think TB. I know that we're all in the middle of the COVID pandemic, and our focus is very much on COVID and detection of SARS-CoV-2. And because TB is a respiratory illness, there certainly could be confusion over diagnosis or maybe delayed or misdiagnoses because of that. And certainly in the state of Florida, we have had a couple of cases where COVID was suspected, but the SARS-CoV-2 assays were negative multiple times, but it was a week or two before a diagnosis of TB was established. So we must continue to think about TB during this pandemic and reach our goal of TB elimination. So thank you very much for your attention today. I'd like to thank my fellow staff at the Bureau of Public Health Labs that worked on this testing. We work very closely with the Florida TB program and specifically the project with Duval County Health Department and Pinellas County Health Department. Thank you, and I'm happy to answer any questions.
Thank you, Marie-Claire, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many questions as we have time for. All right, let's go ahead and get started. Our first question is, how do you compare IGRA tests to TB culture tests and PCR-based tests?
IGRA tests are designed to detect the cellular immune response to MTB, whereas TB culture tests and any PCR tests are detecting actual TB organism in a specimen. So the target of what it is testing is slightly different, and IGRA can be used to detect LTBI, so latent TB infection, in addition to being able to detect active TB disease. When we would use culture and PCR, we're really using that to detect active TB disease.
Great, thank you. Okay, your next question. What is the Florida Health Department's experience using serial IGRA sampling of individuals whose first IGRA test is positive and a second sample collected within the following month is negative?
So within the Florida Department of Health, we sort of try to adhere to the recommendations and not really perform serial sampling in this manner. However, it does sometimes happen that a person gets two tests within a short period of time and we get discordant results. And that's really when the TB program and TB medical director get involved and look at the clinical picture to determine the next steps. I think we know that with IGRA, especially with serial testing, you can get test variability, and so that's why serial sampling is not really recommended, as well as using IGRA to monitor treatment.
Now, your next question has a couple parts to it, and it says, at what stage can a person be infectious regarding TB? Besides active TB patients, can someone with latent TB transmit the microbacterium to others who come in contact with him?
So no, with latent TB infection, this is an inactive phase of infection, and therefore somebody with LTBI is not transmitting disease. However, the challenge with latent TB infection is that it can progress to active disease, and once it has progressed to active disease, then that person is capable of transmitting TB. And I think that's sort of highlights what I was talking about at the beginning of the presentation about how we can really prevent a lot of TB transmission by detecting and treating latent TB infections so that those persons do not progress to active disease and have the capability to transmit.
Great, thank you. Now, are there more techniques that are being developed to detect LTBI, one that is affordable so that developing countries can benefit from it?
So I'm sure there are people working on techniques to develop maybe cheaper and easier to use rapid diagnostics, but I'm not really involved in that's what I can't speak to any of that. I do know that, of course, the expense of IGRA is a drawback of the assay, and of course, it's being done in a laboratory setting with all the quality parameters in place. So certainly, it does add an expense to the test.
Do you think TB screenings should be conducted on college campuses where students from all around the world are in close contact?
So my understanding from the recommendations is that widespread screening at college campuses isn't recommended. I think the recommendations for screening are really looking at persons who are at high risk coming from countries where the risk of TB is increased. So like I said, I don't think it really supports screening of all students where the majority of them are going to be at low risk, but certainly identifying those high-risk persons and getting them tested would be key.
Great, thank you. Okay, your next question, how were the single tubes kept in the field once blood was drawn? In the cooler, fridge, for example?
Yes, for our single tube draws, we recommend collecting and placing in a cooler. And with the project that we had with Pinellas County, which required them shipping FedEx overnight to us, they shipped on cold packs. But that seemed to be okay in the Florida heat. We didn't have any issues with our pre-analytical part of the assay there. So it was a pretty easy process.
Thank you. Now I see this question popping up quite often. A lot of users want to know if your slide deck will be available, and it will be. So just to let everyone know in the audience, if you join the webcast following the live broadcast, come back into the studio, and there will be a link for you to download the slides within the studio. Okay, now let's go ahead and move on to our next question. Do you see many patients who flip-flop around the cutoff?
So we have not seen that a lot because of the patient population that we have been testing based on the two initiatives that I mentioned in my presentation, working with two of our county health departments. So one population there was this shelter card program with the homeless population, and we know that the homeless population is at greater risk. And then the other cohort with Pinellas County Health Department was specifically related to an exposure and a contact investigation. So the patients we're looking at are at a higher risk, and so we haven't really seen that flip-flop. Where people talk about that wobble has been with healthcare providers that are tested on some sort of regular basis and sort of seem to waver around the cutoff and be positive at one time and negative at another. But we haven't really seen it.
Now, for this next question, it says, are you aware of an increase of new cases during this coronavirus pandemic?
If anything, we have actually seen a decrease, and I would say that our volume of samples coming into the lab is between 50 and 60% of what it was this time last year. And I really think that is because people are not coming into the TB clinics to get tested. But we also know that people have been staying at home and staying in lockdown. So time is really going to tell what impact COVID has on TB testing. Will there be persons with TB with a misdiagnosis because they haven't accessed care? Will there be additional transmission? I mean, I think we don't know the answer to some of those questions, and it's you know, as I said, time is going to tell. What I obviously, you know, said at the end of my presentation is, you know, this importance with educating our healthcare providers to continue to consider TB specifically in high-risk populations, because it is in many times obviously with pulmonary TB, it is a respiratory illness. There can be some similar symptoms between COVID and TB infection, and so maintaining TB on that differential diagnosis for patients will be essential.
Okay, we have time for just a few more questions. And your next question says, will IGRA be able to detect the immune complexes in immunocompromised or immunosuppressed patients as they are more susceptible to TB?
Sorry, can you repeat the question?
Of course. Will IGRA be able to detect the immune complexes in immunocompromised or immunosuppressed patients?
So IGRA, the current formulations of IGRA, both the T-spot and the QuantiFERON Gold Plus, can detect interferon gamma in both immune competent and immune compromised patients. So yes, there are obviously going to be some cases, which I did discuss a little bit in my presentation, of anergy, where you may get a false negative in severely immune compromised persons who are not eliciting a T-cell response at all.
Great, thank you. Okay, this audience member wants to know, which pre-analytical system do you use?
I'm not sure I'm clear on the question, but obviously, you know, in terms of the pre-analytical process, and I talked a little bit about that's where errors can occur that can lead to indeterminate rates. So obviously, following the pre-analytical steps of the protocol very clearly is important, and we actually monitor our pre-analytical process based on our indeterminate rate. So our indeterminate rate really informs us as to whether the pre-analytical process is being performed appropriately or not. And I did see a question, and I can just answer it quickly, that said, what's that indeterminate rate? And it's below 0.5%. So it's really low. But that also comes with a lot of outreach and training, and because it is working very closely with our county health departments, we've been fortunate in that we have mitigated a lot of those pre-analytical issues that can occur.
Thank you so much, Marie-Claire. We have so many great questions, and any questions that we do not get to today, will be addressed via the speaker, via the contact information that you provided at the time of registration. So let's go ahead and move on to your final question. Did you have one specifically, Marie-Claire, here in the queue that you would like to answer? Because I just asked the next one. I know we have a lot.
You could just ask the next one.
Okay, great. All right, so let's see. Okay, would you recommend using QTF over T-spot assay, and why?
So, I mean, I can't really recommend one over another. I just have our experience of using the QuantiFERON and can just say that we like using the QuantiFERON Gold Plus product because we can automate it in the laboratory. I talked a little bit about, we perform it on the Agility, which automates the EIA, but now with options, totally automated options like the Liaison XL, I think there are certainly advantages to the QuantiFERON assay in those terms. And now with the single tube draw, that's also an advantage that the QuantiFERON TB Golden Tube assay did not have because the T-spot was a single draw. And one of the other great things about the Plus is having the TB1 and the TB2 tube now, so that it's detecting CD4 T cell and CD8 T cell responses, so an improved sensitivity to the assay.
Thank you so much. And Marie-Claire, do you have any final comments for our audience before we go today?
No, thank you everyone for your attention and your questions, and any questions that I haven't been able to answer today, I'd be happy to answer offline by email.
Thank you again for your time today and your important work in public health. We would also like to thank LabRoots and our sponsor, DiaSorin, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their questions. Again, as a reminder, any questions we did not have time for today and those that are submitted during the on-demand period will be addressed by Marie-Claire via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.